Chapter 19, The Apprenticeship, Community-Based Education, Longitudinal Clinical Clerkships, and Work-Based Learning. There is no better way to learn than from work-related experience. This requires careful monitoring and supervision. The apprenticeship model. In the 19th century and earlier, doctors were trained as apprentices to practicing doctors. The master accepted the pupil, who paid for the privilege and was taught and instructed in the methods and secrets. In the late 19th and early part of the 20th century, the lack of attention to the scientific basis of medicine in undergraduate education, the lack of a formal curriculum, and the varying quality of the apprenticeship experience offered led to a significant shift towards university-based education. The emphasis was placed on more formal and theoretical education in the classroom and on the didactic lecture. Over the years, there has been growing disquiet about the removal of much of the education from the clinical setting, and today greater emphasis is again being placed on learning on the job and the workplace setting, including the community. The learning experience, however, is being more carefully arranged and monitored, with on-the-job learning incorporated as part of a more formal planned curriculum. Trends in curriculum planning. In planning a curriculum, there has been a move as described in earlier chapters, from theory to practice and on-the-job learning with the concept of the authentic curriculum, from hospital-based to community-based learning, from short discipline-based attachments to longer, more integrated attachments delivered through what is described as longitudinal clinical clerkships. In this chapter, we look at community-based education, the longitudinal clinical clerkship, and more generally at the concept of work-based learning. Community-based education. What is community-based education? In the past, medical education was almost exclusively based in a teaching hospital. The vast majority of healthcare, however, occurs in the community, and a recurring theme in curriculum planning has been the need to move medical education from the hospital end of the spices continuum in the direction of the community end. Community-based education refers to medical education that is based outside a tertiary or large secondary level hospital. It is usually based in general practice, but may include other community experiences or work with other healthcare providers. Community-oriented education refers to an education program that is designed to teach about healthcare in the community, with some components in the community and others in a teaching hospital. Rationale for community-based education. Some accrediting bodies now require a curriculum to include a community-based element. There are strong reasons for including a significant emphasis in the curriculum on student experience in the community. These reasons are: community-based education provides students with experience of common diseases and conditions which they may not see in the hospital context. Students see patients from a holistic perspective in their social context. Some learning outcomes are more easily achieved through a community attachment, including teamwork skills, professionalism, cultural competence, and an understanding of community health problems. Students gain an understanding of the interactive roles that social conditions such as education, housing, and economic factors have on health. Some students are motivated by their experience to take up their career in general practice and are helped to prepare for this. The involvement of the local community in the education program for students is consistent with a social contract between the school and the local community which it serves. Community-based experience, if integrated in the early years, can be used to demonstrate the relevance of basic sciences to medical practice. Students are facilitated in forming their identity as a doctor. Clinical training slots are provided in addition to those in the hospital setting, which helps to accommodate the increase in the number of students admitted to study medicine. Urban and rural settings. Community-based experiences may be offered in urban or rural settings. In Australia, some medical schools have rural clinical schools where students receive a large part of their clinical training. Students learning in a rural setting have been found to perform as well as or better in examinations than students engaged with a hospital-based experience. Implementation of community-based learning. While many medical schools now include elements of community-based education in their curriculum, a few schools have community-based education as a major curriculum focus. Schools with a commitment to community-based education are members of the network towards Unity for Health. In implementing a community-based program, consideration should be given to a clear specification of the learning outcomes expected in relation to community-based learning. Where students have both hospital and community-based learning, there should be an indication of the learning outcomes that can be achieved more readily in the community than the hospital-based context. Alignment of the assessment with the community-based experience, irrespective of whether the assessment is a written examination, an OSCE, or a portfolio. Involvement of all stakeholders, including the curriculum managers and designers, the teachers in the community, patients, and the local community. Briefing and training where necessary of teachers in the community with regard to the curriculum, the expected outcomes from the community attachment, and the educational strategies adopted, ensuring that internet connections are easily available and there is access to online learning resources by students at a distance from the medical school. Provision of a study guide for students to assist them in making the greatest benefit from the opportunities available. Making available a mentor or support for the students should this be required. Recognizing and rewarding contributions made by local teachers to community-based teaching. Longitudinal integrated clerkships. The problem with the traditional clinical clerkships. The clerkship has been a major element in medical education programs. Problems associated with the traditional hospital-based clerkship model are students see patients only for the short period of time they are in hospital and do not see the continuity of care. Patients, often admitted through accident and emergency departments, do not represent the wide range of minor or chronic illness. Access by students to patients is difficult because of the short duration of their stay in hospital or the intensity of their investigations. Clerkships are in different specialties with the emphasis on specialization rather than on integrated care. It is difficult for students, because of the short duration of clerkships, to have a meaningful role in the delivery of patient care. Features of LIC. As a result of the above difficulties, LICs have been introduced to replace or complement the traditional clinical clerkship. The features of the LIC are students have a continuing relationship with patients for an extended period of time, up to 1 year. This highlights the importance of continuity of care. Students have a continuing relationship with their teachers and are able to build long-term learning relationships. Students participate in integrated clinical care involving a number of disciplines, professions, and other members of the healthcare team. Students actively participate as members of the healthcare team with their learning interwoven through the continuities of patient contact and care. Implementation of LICs. LICs are based most commonly in the community, both in urban and rural settings, but may also be based in the hospital setting and ambulatory care. In the implementation of our LIC, similar issues should be addressed to those described for community-based education. The student's schedule should provide the required mix of patients and learning opportunities and should relate to the core curriculum for the school. More formal case conferences and other learning opportunities may be included. Students can engage in shared learning opportunities online with other students at different sites. Many schools around the world have adopted LICs as an elective or option in their curriculum, and some run mandatory LICs. A consortium of longitudinal integrated clerkships provides a link with schools who have adopted or are considering adopting LICs in their curriculum. Work-based learning. What is work-based learning? Work-based learning is a key strategy in postgraduate and continuing education, but it is relevant through an undergraduate education. It can be seen as a continuum that stretches from formalized training at one end, where a student or junior doctor learns under supervision, through to an established practitioner sharing a clinical problem with colleagues as part of their continuing professional development. A number of terms have been used to describe WBL. These include on-the-job learning, service-based learning, experience-based learning, learning from practice, and situated learning. Community-based learning is often interpreted as work-based learning. The key feature is that students and trainees participate in authentic activities that form the basis for their learning. They learn from their experience and are helped to generalize from the patient they have seen to other patients and situations. Students or trainees learn on the job while doing the job. Learning in the workplace enables students to learn about the context in which they will later practice. Principles of work-based learning. WBL has powerful learning potential. A key underlying principle is that learning is inherent in everyday practice. The core condition for WBL is supported participation. This involves the learner taking responsibility for seeking out and engaging in learning experiences, being actively involved in the context of the task being undertaken in the work situation, reflecting on their learning experiences with mentors, supervisors, teachers, and peers, interacting with colleagues and other members of the healthcare team, receiving ongoing feedback from mentors, supervisors, teachers, and peers. Advantages of WBL. Learning on the job in the clinical environment offers a number of advantages. WBL focuses on real problems in the context of professional practice. Relevance, a key principle for effective learning as described in the FAIR model in Chapter 3, is a feature. It provides students, trainees with the satisfaction of doing a real job in an authentic work setting rather than engaging in an academic exercise. WBL requires active participation and feedback through other elements in the FAIR model. In WBL, students learn more effectively through doing and through opportunities to practice, particularly when feedback is provided. WBL, by its very nature, can be designed to meet the needs of the learner. Individualization is the fourth component of the FAIR model. WBL offers a multi-professional experience that can help students and trainees to work as a member of a team and develop their professional identity. Experience on the job can help students and trainees to make a career choice. Students on the job experience, such as shadowing house officers in their final year as medical students, may prepare them for their subsequent posting after qualification. It helps them to become familiar with the work environment in the context of healthcare delivery. It may also help to enhance employment prospects for a particular post. Implementation of WBL. Unfortunately, the full potential of WBL is often not realized, and the expected learning outcomes are not achieved. The teacher can take several steps to optimize the potential of WBL in undergraduate education and postgraduate training. Plan the experience carefully, matching the learning experiences to the expected learning outcomes. What conditions are the student or trainee expected to see, and what procedures are they expected to carry out? Unless planned carefully, the school of experience is no school at all. Make the expectations explicit and draw up and agree a learning plan with the students, trainees. Monitor the learner's progress and provide constructive and timely feedback. Recognize the potential contributions of other members of the healthcare team to the students and trainees on the job experiences. The development of satisfactory relationships is an essential part of the exercise. Recognize the importance of the education environment. Students or trainees who are made to feel welcome are more likely to engage actively in the full range of learning opportunities provided and are more likely to play an active role within the team. The concept of the education environment is explored in Chapter 21. Make medical students an integral part of the patient's care. This may involve the student participating in ward rounds and in some aspects of the patient's management. A student's notes, for example, may become part of a patient's records, although this and other students' participation can present a legal challenge. The learner may benefit from a job aid that provides step-by-step guidelines for the tasks expected of them. This is particularly important when a task is lengthy or complex, and when the consequence of error is high. A job aid may be presented in print format or electronically through a mobile device. A study guide can help the student or trainee to understand what is expected of them in the workplace and how they can obtain the maximum educational benefit from their experiences. The guide will help to relate these experiences to the other elements of the training program and to relate theory to practice. Additional learning experiences such as the use of simulators that may enrich their experiences in the clinical setting are identified in the guide. The use of study guides is described in Chapter 15. Figure 19.1. A negative attitude of the teacher can impact the student's learning. Problems and pitfalls of WBL. Problems and difficulties may be encountered when WBL is implemented. The learning may be opportunistic and based solely on the patient seen by the student or trainee. Some repetition of experiences is useful, but unnecessary repetition should be avoided. The level of responsibility allocated to students or trainees in the delivery of the health care to the patients may present a problem. It is important that learners are not given tasks beyond their capabilities or authority. A conflict is sometimes perceived between the educational needs of the doctor in training and the service delivery demands. In WBL, the relationship between the education and service components should be made explicit, and the education integrated with the service delivery. The learner's progress needs to be carefully monitored and appropriate feedback provided, otherwise the learner is in danger of becoming like the golfer who continues to practice his mistakes but does not improve his game. Inappropriate or lack of feedback is a common criticism in WBL. The assessment of the student's progress and their achievement of the learning outcomes can be challenging. Non-traditional methods of assessment may be required, and these are discussed in Section 5 on assessment. Figure 19.2. Inappropriate feedback may be a problem. There may be funding implications for the medical school in undergraduate education where money follows the student. In postgraduate training, there may be implications for the hospital if the employment of junior staff attracts higher insurance premiums.